Hi everyone. We're going to start today's micro lecture with the big question we answered in the previous lecture. Well, we asked in the previous lecture. That is, what is results? New public management is meant to be about accountability for results. What do we mean by that? Well, in this lecture, we're going to sort of substitute the word results for the word performance, because that's the word that's been most commonly used in public management for the last 30 years. And I'm going to introduce to you the language of performance, which is the language of inputs, processes, outputs, and outcomes. A couple of other topics to cover before the lecture. Right, so today's lecture we address a very practical question. If it's important to hold government and non-government organisations accountable for performance, how is that done? What things are they accountable for? In this slide and the next slide, I'm going to introduce the terminology of performance as it's been used since the 1980s. The three key terms are inputs, outputs, and outcomes. And a little later, I will mention a fourth term, processes. Let's take an example of making a cake. To make a successful cake, you need to have the right set of ingredients: flour, butter, eggs, sugar, whatever else. And these things are called inputs. Now we can think of the cake itself as the output. And then we can say, why make cakes at all? What's the value of making cakes? Well, you could say it's to make people happy or satisfied. In that case, those are the things that we can think of as the outcomes of making a cake. Now let's apply these ideas to the things that governments do. So we'll start with inputs. Inputs are resources. So that covers things such as employing staff, getting the right equipment needed to provide a service. So two examples for bowel cancer screening services. It would be the amount of staff, the specialists, the nurses, the administrative support, the IT services to set up a screening register, the laboratory equipment to process screening tests. For health promotion services, say designed to prevent rheumatic fever, the inputs again would be the staff and whatever equipment would be necessary to provide that service, such as information technology. Now, outputs, let's go. They are the things that are done, the services or the goods that are produced or delivered. We can think of them as the direct and measurable products of a program's activities or services. So what does that look like in our two examples? You could measure the outputs of a bowel cancer screening program in terms of the number of patients screened, or perhaps the percentage of eligible population that was screened. Or you could measure the performance of a health promotion organisation in terms of outputs, and that would be, say, how many information sessions or seminars it provides for a local community. So outputs are the things that are done. And outcomes are the effects on the broader community, things that really matter, arguably. So remember in the cake example, the outcome is the satisfaction of those who eat the cake. So in policy implementation, outcomes cover a wide range of things. With outcomes, we're back in the territory of values. Outcomes are things that are valued. So for bowel cancer screening, the outcomes would be population health outcomes. Does the program eventually lead to lower morbidity and mortality? For health promotion services, the outcome could be lowering the rate of rheumatic fever in the local community. Or perhaps it could be something a little less distant and a little closer to the activities themselves. So, such as simply improving the local community's understanding of rheumatic fever. So that's an example of something we could call an intermediate outcome. Now, we've talked about contracts as a central feature of public management and of service delivery and policy implementation. So any of these things, inputs, outputs, and outcomes, are things that could be specified in contracts where you have a purchaser and a provider, and the purchaser wants to purchase things. Those could be inputs, they could be outputs, they could be outcomes. Now, just before we move on, I just want to say a few words about outputs and processes. So in the earlier description of outputs, you might have spotted a potential issue. Let's say an organisation or a service is assessed or contracted in terms of how many things it produces. Well, one possibility is the managers of the organisation might be tempted to prioritise quantity over quality. So if I'm a cake maker and I'm assessed or rewarded on the basis of how many cakes I make, well, I could slap the ingredients together in any old way and I might only bake it for half the required time. What comes out of the oven, I could still call it cake, but it's going to be a pretty awful cake. So generally, if you measure performance in terms of outputs, it's important to build in some elements of quality control as well. And that generally means assessing processes. So in bowel cancer screening, you need to balance how many FOBT tests were taken with the quality of the processing and the analysis of the samples. In the health promotion example, if all that counted were the number of health promotion events delivered, well, you'd want to balance that in some way by ensuring, I don't know how, that those events were of sufficient quality. So processes are prominent in contracts in order to ensure that quality, however defined, is not sacrificed for the quantity of outputs. But in terms of contracts, we'll see a bit later, processes and outputs work in similar ways. And so we're going to sort of think of those as two examples of the same type of thing. So contracts specify what is produced and often they also prescribe how things are to be done as well. Okay, so that's the terminology. Now I want to explain what has happened in Aotearoa, New Zealand. Now, this whole language of thinking of government in terms of inputs, outputs, and outcomes was part of the shift to new public management in the 1980s and 1990s. So you will remember that NPM was about results, and you already know that inputs are not results. However, both outputs and outcomes can be thought of as results. So the cake is a result of the cake making process, and the satisfaction of the cake eater is a result of having eaten the cake. But which of these two things, outputs or outcomes, matters most in new public management in New Zealand? Well, here there's been a very distinct answer to this question, which might surprise you. In the 1980s, Treasury, the key advocates, the government agency that were the key advocates and designers of our system of public management, they came to the view that the government and non-government organisations involved in delivery and implementation needed to be responsible and accountable for outputs rather than outcomes. So why was this? Well, it all comes back to the idea of what single organisations can and can't control. So look at any outcome and it's influenced by a wide range of factors. Whether somebody is satisfied by eating a cake also depends on whether or not that person has allergies to eggs or to wheat or to dairy or whatever else they've just eaten. So you might make the best cake in the world, but it could still make me, as someone with allergies to eggs, it'd still make me sick. So rates of rheumatic fever in the community might be affected by health promotion activities, but other bigger things that affect rheumatic fever rates are housing conditions, and health promoters or health promotion organisation doesn't control those housing conditions. So Treasury's approach was that organisations needed to be accountable as agents for delivering outputs because those were the things that they could control. And you might say, what about outcomes? Well, we'll get to that in a minute, but this responsibility for outputs flowed into the use of contracts as informed by principal agent theory. So the principal, which could be the minister or the Ministry of Health or a DHB, would then purchase which outputs it wanted from providers. And sometimes these contracts are still known today as purchasing agreements. Oops, I don't want to go back. Okay. So the language of purchasing and provision is still prevalent today. Within DHBs, people still refer to the purchaser arm and the provider arm. And the purchaser arm is the part of the DHB that negotiates and draws up contracts with non-government providers of primary care, mental health, and health promotion services. Now, key doctrine internationally in new public management was let managers manage. Tell them the results that are required, but let organisations and managers work out how to do it themselves. However, Treasury's approach was that it was the job of ministers to decide which outcomes were important, and then ministers would choose the combination of outputs that would lead to the desired outcomes. They would decide which outputs were worth purchasing in order to produce the outcomes that they wanted. And that's why implementing organisations were responsible for producing outputs, not outcomes. Now, the whole idea that ministers would have the necessary information to choose which outputs would produce the outcomes they wanted is based on a whole lot of heroic and unsustainable assumptions. And here you might recall some of the material from Module 1 on bounded rationality. However, even though people don't talk in those terms anymore, what was important as a result of this period was that the whole system of public management was pretty much built on this idea that public service organisations and other organisations were accountable for outputs and not outcomes. So the whole logic of accountability for outputs had been well established by 2000 and hardwired into how government works. Even at that stage, most observers realised that the idea that ministers purchase the outputs necessary for producing outcomes, most people realised that was untenable. But the system, the decisions made then have major implications for what has happened since. So, what are some of the problems with what's happened in the last 20 or 30 years of this NPM approach? Well, the first thing to say is that there are some areas of government where this approach has worked pretty well, where there is some clear connection between outputs and outcomes. But it's also very clear that health is not one of those areas of government where this is common. As such, NPM and output accountability have resulted in some major problems in the health sector. So firstly, there are typical problems for providers, particularly the non-government providers of publicly funded services. And this, by the way, is the main topic of your tutorial reading for this week's content. Now, the first obvious problem is that organisations that have output-based contracts find the outputs that are described in those contracts meaningless and trivial. Not all the time, but very often. So, health promotion organisation contracted to provide a certain number of health promotion activities might say, why can't the contract be about making a difference? Why can't it be about outcomes? Rather than outputs which people describe in derogatory terms as simply counting widgets. Second problem, and perhaps a more serious problem than that, is a consequence of the importance of competition and contestability in new public management. So most non-profit NGOs are in a very weak bargaining position. They are often reliant on contracts with government organisations, and that means that they often bid for contracts knowing that the money they receive will not actually cover their costs of providing the services. So in many cases, NGOs have not received any real increases in the amount of funds that they get for over a decade. basically the principal, the DHB, for example, can drive the costs down. Say, well, fine, if you don't want to provide a contract, provide a service for this price, we can find some other organisation that is prepared to. So in that way, they can push the price down. Great for the government's books, not so good for the non-government organisation. The third problem is that non-government providers in this environment see each other as competitors rather than collaborators. And the consequence of that is that they don't trust each other because they're competing for contracts, and they are reluctant to share information with each other. And a fourth problem for providers is what has been called overburden. So a single NGO might have multiple contracts with a single funder or multiple funders. And it takes a lot of organisational effort and energy to know and understand which contracts cover which services, as well as reporting on those contracts. So there's a supplementary slide at the end of the PowerPoint presentation that shows what this overburden can look like. Now, then there are the problems that have arisen when we look at the whole system of contracting for outputs and what it has produced. So the first problem here is what's known as the checklist mentality. So output-based contracts often produce a long list of boxes to be ticked. The focus on meeting outputs and process requirements can cause both principals and agents to lose sight of why they are doing things. A second problem is transaction costs. So organisations, both the funders and the providers, spend a lot of time tendering for contracts, bidding for contracts, drawing up contracts, monitoring contracts, renegotiating contracts. For provider organisations, none of this time and activity is funded. They just have to work out a way to do it. But for all sorts of organisations, the administration of contracts is a huge part of what they do and soaks up a lot of resources. Another major problem in health is that NPM output-based accountability is a big contributor to service fragmentation. So one organisation might hold a contract for services relating to sore elbows, and another organisation has the contract for services relating to sore knees. And these organisations don't talk to each other because they are competitors. But it might be the same person that has a sore elbow and a sore knee. I'm using those examples rather facetiously, but you could substitute in other areas of services that are fragmented, even though the same person might need both those services. And that leads to the fourth problem, which is the institutionalization of distrust between organisations. And that could be between purchasers and providers, principals and agents, or it could be between provider organisations who compete with each other. So when you're looking at this list of problems, you might notice some parallels or things in common with the problems associated with bureaucracy and hierarchy we covered earlier. So many of the problems that NPM was introduced to address have actually reappeared in a different way as a consequence of new public management. And I'm happy if you want to ask me some further questions about that. Right, so it's fair to say that there is widespread dissatisfaction with output accountability in NPM in the health sector, and that's that's true in countries other than New Zealand as well. But the question we're left with then is, are there other ways of coordinating service delivery and implementation? And another question you might ask is, can we keep some of the benefits of this system of contracting but make it more about outcomes rather than outputs? So in Wednesday's lecture, we're going to look at some answers to those questions and focus on the third type of coordination, known as networks or collaborative networks, which serves as an alternative to both hierarchies and markets. All right, I will see you then.